All right, greetings, and thank you for joining us on session 6 for the Lurie Children Sleep Medicine Roundtable. We are super excited to have this session today as we are doing our first multidisciplinary discussion, and we're going to have it between our sleep medicine interim director, Dr. Trosman, and 2 ENT specialists, Dr. Valika and Dr. Ghadersohi. And I just want to remind you all that this is being recorded, and I will be sending links out to you tomorrow. If you can share that with your colleagues, I'd appreciate it, as there has been a great demand for these sessions for sleep medicine, and especially with the sleep medicine and ENT multidisciplinary talks. So I encourage everybody to ask your questions in the chat room. And if afterwards, after the discussion, and you have questions, go ahead and raise your hand. We can go live as well. So without further ado, Dr. Trosman, why don't you go ahead and take it away, and we'll see you all shortly.
Thank you, Chad. Good afternoon. I'm honored to be joined by my 2 favorite colleagues who are helping us in our department to take care of very complex patients. So thank you. We'll be talking about pediatric obstructive sleep apnea, or POSA, today, and we hope to create a little dialogue, which is actually pretty much a replica of dialogue that we have when we deal with these patients, and some of those dialogues are via epic medical records or in-person communication. Regardless, we're in touch, and we're sometimes even seeing patients together and hoping to promote this multidisciplinary clinic approach. So let's start by talking about what we will review today. So we'll briefly review pediatric sleep apnea, etiology, symptoms, pathophysiology, most importantly, evaluation and treatment options. And we'll present few cases that are based on our real patients and emphasize individualized and multidisciplinary approach to their evaluation and treatment. So very briefly, the estimated prevalence of sleep apnea is 1 to 5%. That's based on the sleep studies, but you can imagine there's a fair amount of patients that doesn't get referred to sleep studies and undergo surgeries or treatment just based on the clinical diagnosis. So the true prevalence may be higher. And of course, those studies are based on the patient population studied and researched decades ago. So we really think that the true prevalence is higher, especially with increased incidence of obesity. The traditional thought, the etiology of sleep apnea, is adenotonsillectomy hypertrophy, which is true, but we now see more and more patients with obesity, which is probably the second most common cause, or we see an overlap. And of course, patients with anatomic abnormalities, laryngomalacia, low muscle tone, retrognathia, and a combination of any of the above mentioned factors could be your patients that you will be seeing in your practice. So at this point, we even think about 3 different subtypes of sleep apnea. Congenital type, which is mostly related to anatomic abnormalities or low muscle tone. Childhood onset, mostly related to adenotonsillectomy hypertrophy, the classic adenoid phases. The adult subtype, which is more related to obesity. And what we frequently see is the overlap between all 3 of them. And the reason to think about this as subtypes, because the pathophysiology and clinical manifestations may differ a little bit. So for instance, in infancy, you will see more patients who are struggling to gain weight or even fail to thrive. With childhood subtype, you will see probably more kids who have nocturnal disruption and behavioral dysregulation. And with an adult subtype, in addition to dysregulation and behavioral aspect, you may see cardiovascular and metabolic morbidity, similar to the ones that you will see in adults with obesity and sleep apnea. We now understand that pathophysiology of sleep apnea is not very straightforward. It's not just the size of tonsils and adenoids or just the retropharyngeal phase size, though there is definite correlation between the posterior airway size and severity of sleep apnea. We also realize that children with sleep apnea have more collapsible upper airways. And it's important to remember that this collapse occurs primarily during sleep. Therefore, if we were to get a static picture, for instance, an upper airway X-ray, or if we're looking at a child's airways, remember we're looking at the wakefulness stage, and it may not reflect what really happens during sleep. So it's really complex relationship, and that's why it's important to try at least to estimate the pathophysiology that occurs specifically in sleep and how this complex mechanism plays out when the child's airways are relaxed. We definitely know certain conditions predispose children to have severe sleep apnea, such as significant frequency of upper airway infections leading to adenotonsillar hypertrophy, or allergies that cause significant upper airway congestion and turbinates hypertrophy, obesity, asthma, and allergies, sickle cell disease, obviously any kids with craniofacial abnormalities or low muscle tone, or chronic lung disease. And when we look at sleep at the physical examination, of course, the classic findings, adenoid phase, mouth breathing, allergic craze, but don't forget about dental findings. Overchat, overbite, or underbite could be signs of chronic mouth breathing. High arch palate that you can see at the bottom are also important indications that the tongue posture is changed because of mouth breathing. Common daytime symptoms in pediatrics can vary from hyperactivity and attentiveness to frank sleepiness. And nocturnal symptoms are similar to adult sleep symptoms with adults with obstructive sleep apnea, but I want to emphasize few exceptions. Children do have a tendency to sleep with hyperextended neck. They may have nocturnal enuresis, including secondary nocturnal enuresis, as opposed to nocturia in adults. And because they spend more time in deep sleep, any arousals or awakenings from deep sleep triggered by sleep apnea may cause parasomnia. The manifestations of sleep apnea, especially daytime symptoms, are probably a reflection of significant sleep fragmentation. And the sleep fragmentations are basically this micro awakenings or true awakenings as a result of obstructive events. Disrupted sleep architecture, we know that a lot of events occur in REM sleep, so REM sleep could be disrupted. And as a result of significant gas exchange abnormalities, specifically hypoxia and hypercapnia, those changes affect cardiovascular health and can potentially affect cerebral oxygenation and endothelial health, though some of the data is mostly deriving from adult studies. So let's take a look at the real example. We have a 2-year-old child with snoring, loud breathing, restless sleep, night terrors, and mouth breathing. Her exam is remarkable for tonsillar hypertrophy. We suspect she may have adenoid hypertrophy. What would be the appropriate next step? Should we send her for a sleep study? Should she see a sleep physician if you are thinking about this child in the context of primary care visit, or shall she go and see ENT? And as a primary care physician, if you were to choose to do a sleep study, what you may see is this example: a child who is seemingly sleeping. The top brain activity is indicative of sleep. In R stands for REM sleep. You can see a rhythmic artifact that is representing snoring, a brief awakening, a big breath during this awakening, and a little movement artifact. And as far as her breathing, you can see normal breath and then shallow breath, no breathing for about 10 seconds or so, and then this recovery breath that coincides with brief awakening. That's sort of a rescue awakening in response to an obstructive event. So obstructive event. And this little moment associated with a rescue awakening, which allows the child to resume breathing. So if you were to look in real life at her sleep study, you may see this very disruptive sleep pattern where on the top you can see frequent brief awakenings represented by red bars associated with increase in muscle tone and movements. You can see frequent desaturations from 94 to 70s or even 60s. This is a child who's been admitted to the hospital directly from the sleep study, and essentially complete cessation of breathing, this red bars where we see no airflow, continuous efforts on the part of our chest and abdominal belts and intercostal muscle, but it's futile until the child briefly wakes up, breathing resumes, continues for a few breaths, the child returns to sleep, and the next obstructive episode ensures. The overnight sleep study picture or a hypnogram demonstrates that every time the child is in REM sleep, and you can see the REM sleep represented by these green bars on the top, she experienced considerable amount of obstructive events, green hypopneas, red apneas, and brief desaturations. This is the oxygen saturation line. You can see desaturation mostly coinciding with REM sleep. So what would be good the next step? Let's say she comes to your ENT practice, my colleagues. What would be your approach?
So the first line treatment for any patient with sleep apnea is typically adenotonsillectomy. This has been studied for years and years and years, and doing tonsillectomy and adenotomy has been shown to be much more effective than if you did adenotomy or just a tonsillectomy by itself. That being said, the studies as they've looked at it and kind of parsed it out in terms of the baseline populations that they're studying, the success rate can vary. It can range, depending on the study you look at, anywhere from 24% to 100%. And those patients that are particularly overweight or obese or have severe sleep apnea to begin with have the lower success rates. Now, adenotonsillectomy is not an easy procedure. It does have morbidity and mortality associated with it. And because of that, there's been some different techniques and things that have come up over the years versus it's a traditional kind of extracapsular technique where the entire tonsil is taken out, or an intracapsular technique where part of the tonsil is left alone. That difference is done and thought to have reduced bleeding risk and reduced pain risk afterwards. And one other thing that has kind of changed over the years is most centers now rely on a regimen of acetaminophen and ibuprofen, and that's typically what's recommended by the guidelines. Again, most centers are okay with ibuprofen. It hasn't been shown any significant increase in bleeding risk. And the one thing to be aware of is that codeine is absolutely to be avoided because of the hypermetabolizers and the risk of death with the black box warning. So that's definitely something that we do not recommend in terms of post-op care for adenotonsillectomy.
So in retrospect, do you think there was a right decision to send this child to a sleep study? And if it were, do you think it was a right decision? Do you think this sleep study findings change your approach?
So I think, when we look at the guidelines and when we look at the guidelines that are put out by our different kind of governing bodies, whether it's the American Academy of Sleep Medicine, American Academy of Pediatrics, or the American Academy of Otolaryngology, they'll discuss different indications for when to do the sleep studies, and we'll kind of go over that in an upcoming slide. But the sleep study, having this information available, kind of gives you a baseline, and it gives you a lot of information on how to manage this patient in that perioperative setting. Do they need closer observation afterwards? Is there other things that we need to think about outside of tonsils and adenoids? And so in this patient, since they did have severe sleep apnea, definitely would be considering this patient overnight for observation to make sure that the anesthetic doesn't further worsen things.
The other thing also is with, getting a sleep study, you're balancing it out the risk of, the timing that it takes to get the child to the sleep study as well. For a parent who comes in as very convincing symptoms, understanding that their child's obstructing, they have documented videos showing you, look, my child is pausing, you can see their apneas. The sleep study may not necessarily change your approach either, right? Because I think for parents who need that extra objective information and having the data, certain patients, as we'll cover the guidelines, will stay in the hospital regardless. So it's sort of a 50-50. There's certain patients that would benefit from it. I think that's where it's really individualized care instead of having this broad, fixed statements to say every child gets A, B, and C. It's, well, let's talk to child A and see what their approach is better. And how does this impact their care, their requirements, balancing on social determinants of health, access to care, timing of care can make a big difference.
With this in mind for our primary care colleagues, if they see a child they suspect to have very severe sleep apnea, and there are enough convincing clues that to think, and it's a little older child, do you think they should send it to specifically pediatric ENT at the tertiary care center, so that if the choice is not to do a sleep study and to proceed with a TNA, that the assumption would be this child will be in good hands in the pediatric sleep center for an observation, postoperative observation, rather than just sending to someone who practices in general ENT practice and may not be affiliated with tertiary care center with ICU available?
Yeah, I think, by having the resources that we actually have available here, we know that in case they need extra support or anything extra from an airway perspective, we're able to better identify those as we have those resources. And it's something we frequently deal with based on our complex population. So instead of throwing a wrench into it, it's more so like our normal day.
And then for this child that you suspect to have severe sleep apnea, would you consider just seeing for a follow-up, or would you automatically order a repeat sleep study?
I think, most of the time it would be important to get a follow-up sleep study, especially in these kids with baseline severe sleep apnea. Typically about 2 to 3 months after the surgery to kind of make sure that everything's fully healed, and you establish a new baseline. And if there's still residual sleep apnea, then that can determine the next steps in terms of whether it's CPAP, positive pressure therapy, or further surgical measures that need to be undertaken.
So going back to your comments, it's true that sleep studies may involve wait time, especially for those practitioners who practice further away from big academic institutions. They are pricey, and some insurances some patients may have high deductible. It's difficult to do sleep studies in kids. They don't frequently tolerate monitoring equipment, and they should be done in appropriate sleep centers where technologists are well trained. So those, of course, are challenges. But as you pointed out, sometimes they help to stratify who would be appropriate candidates for inpatient observation and give you a baseline. So going back to the differences in recommendations for sleep studies, would you mind reviewing the indications from American Academy of Otolaryngology and highlight the differences in their recommendations as opposed to American Academy of Pediatrics?
Yeah, so most of the guidelines from our academy kind of centers around perioperative management and kind of understanding how this patient's baseline comorbidities may affect the outcome in and around the time of surgery. In a kid who's less than 2 years old, as we talked about, understanding that baseline is important. It's also in kids less than 2 years old, it may be that adenotonsillectomy or enlarged adenoids and tonsils aren't actually the cause. It may be sleep variant laryngomalacia, or as you mentioned, small jaw, or some other kind of anatomic feature that's more at play with the sleep apnea than just tonsils and adenoids. In addition, kids that have other comorbidities like obesity or trisomy 21, craniofacial abnormalities, neuromuscular disorders, sickle cell, or mucopolysaccharidoses, those kids, again, have a high chance of having residual disease. So it's important to kind of establish a baseline and then have the information available for perioperative planning. In those kids that they present and they have obvious symptoms of sleep apnea, they're pausing, parents can show you a video. But when you look in their throat, their tonsils are small, they're 1+. A sleep study there will also kind of help improve the diagnostic accuracy to ensure that you're treating the correct thing. So again, it centers around ensuring that you have the correct diagnosis, determining the severity, establishing a baseline, and then also for perioperative planning to determine what are the management issues.
And so speaking of OSA severity, we know that healthy children should not experience any obstructive events. And we're using this index base that we derived from the sleep studies to determine severity. Having said that, we understand it's not the most accurate estimation. So we categorize sleep apnea into mild, moderate, and severe category, but we also take into account gas exchange abnormalities, specifically the degree of hypoxia and hypercarbia. So this is, again, a real patient that we've seen in the past, almost 2-year-old girl with trisomy 21, G-tube dependent because of dysphagia, failure to thrive, and severe sleep apnea. She already had adenotonsillectomy and has persistent symptoms of sleep apnea. Her most recent sleep study done at our institution shows severe sleep apnea associated with significant hypoxia. What would be the next step for her? And I just want to show you a quick video of this child. So this is an obstructive event, flat line, no air going through her airways, desaturation, and then a big recovery breath, little movement associated with that. So what should we tell the parents? She already had the surgery done.
So, the care of these kids kind of as the next step, I think is important to involve a multidisciplinary care team, because these patients could have multiple options. They could go the sleep medicine medical therapy route with positive pressure therapy, or they could maybe elect to do the surgical route. If they elected to go the surgical route, the first step is to do drug-induced sleep endoscopy. What this is basically we're passing a flexible laryngoscope or a little camera through the nose while the child is sleeping under anesthesia. We're trying to use anesthetics that will kind of replicate what their throat and what their pharynx looks like when they sleep. And we do kind of a level by level assessment of areas that are obstructed. The first kind of top and bottom panels there were on the left side, we're looking at the septum, the nasal septum there. We can see a little deviation. Below that, we see the turbinates, which are enlarged. The next set of panels shows us the adenoids there in the back of the nose. You can see the top one is not so bad. The bottom one is much more severe. The next panel shows tonsils. You can see those little lumps kind of coming from the side of the panel. The top picture again shows smaller tonsils. The bottom one shows bigger tonsils where they're almost touching each other. Next panel shows the larynx and the voice box. We can see the epiglottis there at the bottom. And then the bottom panel below that shows the back of the tongue kind of pushing up against that epiglottis and kind of really filling that space and actually pushing everything further back, which may be the site of obstruction for that kid. A couple other things in the picture, in the pictures on the last column there shows the pattern of collapse in the throat, like how the walls move when the child is sleeping. And the next panel there shows lingual tonsils, the tonsils in the back of the tongue. And then the last panel in the bottom right corner shows the features consistent with laryngomalacia. The arrows are pointing to the arytenoids, the floppy areas of the larynx, which may kind of prolapse over the airway and cause sleep variant laryngomalacia. Now, it's nice to see all the pictures of the different levels. If you go to the next slide, we show a video because the dynamic view is what's really important. Here again, you see the, initially you saw the turbinates there. Now we're seeing the back of the nose with the adenoids, again, kind of filling quite a bit of the nasal pharynx. We see the palate opening, and then now we're seeing that dynamic view of how the throat is moving and collapsing. And in this picture, I wanted to kind of show the tonsils there. This is a child who has not had adenotonsillectomy yet. And we can see that in some of those clips, the tonsils were coming and touching each other. The second video there shows base of tongue collapse. We can see the tongue, the lumpy bumpy structure at the front is the back of the tongue, again, kind of falling backwards and pushing the epiglottis towards the back wall of the throat. We can play it maybe one more time so that if we missed that. And then I think during this, so you can see how bad it is there where it's almost completely collapsed. And then we do a jaw thrust where we lift the jaw forward. And we can see how it really opens up space there and pulls that tongue off the epiglottis.
This helps you to target surgical intervention. Is that correct?
Yes. So if we go to the next slide. So once we've made an identification of which levels are problematic, then we can kind of target our surgical approach. So there's surgeries that we can do with palate in the form of an expansion pharyngoplasty, which is shown in the picture there to kind of tighten up those walls in the palate. We can do nasal surgery where we correct the septum and turbinates. Sometimes that's a little bit limited in terms of doing it in older kids and adolescents because it can have facial growth implications. Tongue-based surgery or hypopharyngeal surgery is kind of the bigger next step where most of our patients would fall, where if they needed a lingual tonsillectomy, a midline glossectomy where we remove part of the middle part of the back of the tongue. Dr. Valika will talk about the tongue-based suspension in one of the cases that we have upcoming. Another up-and-coming treatment is the hypoglossal nerve stimulator. And the recent phase 1 trial was published in the last few months in the Down syndrome population of adolescents. And so we'll see if we can hopefully get that in play and use for that population of kids. Laryngeal surgery, again, if they have sleep variant laryngomalacia, circumflexoplasty may be helpful. And then those really, really complex kids where we, CPAP is not working and there's no great surgical option, tracheostomy can be used to kind of bypass everything.
And I think tracheostomy, for that perspective, understanding while it may seem severe, it's really for that truly complex patient. And that's where that sleep endoscopy is really helpful, because if we realize there's 5 levels of obstruction, in addition to their complex comorbidity, do you really go down this pathway of having a great, a frank conversation with the family? Look, we have 5 areas of obstruction. The likelihood of fixing each one to be able to ensure to prevent the need for some of these things may not get the benefit. So, they're able to make an informed decision based on what we're able to show them off the sleep endoscopy. So it's a truly appropriate consent and realistic expectations for our family members with some of our complex population.
So that takes us to our next case. This is a 4-year-old who was initially sent to us by our ENT colleagues, very complex kid who had a heart transplant and multiple strokes. So clearly has a significant dystonia, dysphagia, G-tube dependent, nonverbal, and has a severe persistent sleep apnea. He's been obstructing during wakefulness as well as sleep. And he could not tolerate, despite our multiple attempts, either CPAP or BiPAP or high flow oxygen therapy. And the family was adamant they did not want to proceed with tracheostomy. So he was referred back to ENT, specifically to Dr. Valika. And Dr. Valika, if you don't mind taking over and tell us what happened.
Sure. So, I mean, as Dr. Trosman described, right, this child has severe sleep apnea, obstructing while awake, really had no other options. Tracheostomy was truly the only remaining option on the table. Tongue-based suspension is a relatively new procedure, and the technique that we're sort of describing here is a technique that we actually developed here at Lurie Children's. We've done the most patients in the world here. We've actually seen excellent results. We've had children ages from 5 weeks to 17 years old who have undergone this and have successful treatment of their OSA. So as we've seen, tongue-based collapse is a very challenging area to sort of treat because there's multiple levels of potential obstruction, and how do you fix that? What we've sort of done is, we're able to use some of our instrument sutures being placed under fluoroscopy. So we'll play the video for you. And it shows us in the bottom right corner of how we actually target the area of the biggest collapse under fluoroscopy with the child asleep, throw the stitch at the place of most obstruction. And then once we have the stitch in place, you can actually see the area where the arrow highlights where we fix the obstruction, right? And that gives us targeted therapy through our sleep endoscopy and using innovative techniques like fluoroscopy. And this child OSA, or his AHI status, went from 81 to 6 weeks later at 0.6, right? And then, frankly, getting that result that we were really craving.
And the kid did beautifully, but that's a permanent suture, right? You don't need to redo it again.
Correct. It's a permanent stitch. It stays in there. The way it's tethered, you can get imaging and it doesn't impact. We haven't had changes in our feeding patterns afterwards either. So other than an incision on the outside, which is unlike most ENT surgeries, yes, we go through the chin, but other than that, we've had great outcomes with this.
Great. So we talked a little bit about risks for persistent sleep apnea. Obviously, we talked about child with Down syndrome or multiple comorbidities. Just the mere fact of being post-pubertal boy or history of prematurity, being African-American, or obesity, severe sleep apnea prior to the surgery. And of course, all the comorbidities that put children at risk for having sleep apnea to begin with are all the same risk factors that unfortunately still there for increased risk of persistent sleep apnea. But keep in mind, there are non-surgical interventions that are available too, even for those who have mild and moderate cases. In fact, some children outgrow their sleep apnea. So it's not unusual for us to try to target their allergies or to make sure their asthma is under good control, work on their weight loss, have collaborative relationship with orthodontists, because there are a fair amount of orthodontic interventions that could be done. This is an example of upper palatal expansion, and myofunctional therapy can be promising as long as the family can find a therapist and adhere to it. Of course, we also use oxygen in younger children. For those who have CP and not mobile, positional therapy could be useful. So those are non-surgical management approaches, though. Having said that, it's important always to take a step back in a few months and see if these approaches work. Oops. So the next slide is going over a brief case of a child who has severe sleep apnea, who already had multiple surgical interventions. She has some craniofacial abnormalities that unfortunately put her at risk of persistent sleep apnea. She still has very severe sleep apnea, and the surgeries are not in the near future. So she was referred to us in 2019, desensitized to CPAP. This is actually her picture. And CPAP is now successfully used. We reassess her every 6 months, hoping that she will eventually outgrow her sleep apnea and adjust her CPAP settings accordingly. So what we would like to emphasize and kind of take away points today, that sleep apnea, unfortunately, is prevalent in our population, especially with increased obesity prevalence, that you don't have to do sleep studies in every child, but you should consider them in younger kids or kids with comorbid conditions, or if you have some discordance between physical exam findings and history. Consider screening for sleep apnea. There are different questionnaires that are available for you during well-child visits. Keep an eye on kids who are at high risk to maybe do a little bit more frequent screening. Adenotonsillar adenoidectomy and tonsillectomy are still the procedures that are considered to be gold standard of care. Further surgical guidance should be led by DICE, drug-induced sleep endoscopy. We do have non-surgical treatment options. And the best thing is, of course, unless it's a very first step, such as ANT, is multidisciplinary approach. And that's what we're advocating. It's a collaboration between our ear and nose and throat colleagues, orthodontists, general pediatrics, weight management, allergists, and psychologists. So with this in mind, we will close and we will open to any questions you might have.
Wow, what a great discussion, you guys. That was everything we hoped for and more. So I think the problem is you already asked all the questions and you guys answered most of the good stuff. You took all my questions already away. So this was really good. But if anybody else has anything out there they'd like to ask, feel free to unmute yourself or to ask in the chat room for that. And thank you for talking about when to refer into which division, because that was really important, Dr. Trosman. You brought that up earlier today in your discussion. It's an important question for our partners out there.
Sure.
But right now it doesn't look like we have any additional questions for you all. So with that, then I'm just going to go ahead and we're going to go ahead and close our session. And just want to thank everybody who's joined us over the last few days for our 6 sessions of the Sleep Medicine Roundtable. This was such a great time and had great attendance and a lot of wonderful questions out there. So we hope to see you again soon, and just want to thank Dr. Trosman, Dr. Valika, and Dr. Ghadersohi for joining us today.
Thank you for inviting us.
Thank you. Have a wonderful day, everybody.
Thank you.
Okay.
Taher, Saied, thank you very much.
You're welcome. Of course, thank you.
Appreciate it as always. Thank you, Chad.
Thank you, Chad.
You're very
Thank you,
welcome.
Chad.